We're delighted to have you all here, so thanks very much for joining us. I'm going to introduce our first keynote speaker, who will be opening the conference and setting the scene for us today. So I'm really delighted to welcome Grania Maloney from UNICEF. Grania is a senior advisor in early childhood nutrition in UNICEF HQ in New York. She leads on the prevention of all forms of malnutrition and the early detection and treatment of wasting in children up to the age of 5 years. Grania has worked globally with UNICEF for over 20 years. She is an Irish national. She holds an MSc in Public Health Nutrition from the London School of Hygiene and Tropical Medicine and a Bachelor of Science in Human Nutrition and Dietetics from Trinity College Dublin, which is myself and co-PI Aileen's alma mater. So we're really privileged and delighted and proud to have Grania here joining us this morning. So thank you very much, Grania, and I will pass the mic over to you.
Thank you so much. Can you hear me, Liz? Does that work?
Yep, I can.
Okay, great. Hi, good morning, everybody. I'm thrilled to be joining you. I am joining you from Cotonou, which is the capital of Benin in West Africa, where I'm participating in a meeting on strategies to improve the diets of children in early life. So it's always lovely to talk about a subject that's deeply close to my heart. But I'm particularly happy to be online to be speaking to my fellow Irish people. This is something that I don't get the privilege to do very often, so I'm delighted to be online and engaging with you all. And I see some friendly faces online as well too, so I know I'll be backed up in the event of any questions. Now I'm going to try and figure out how to raise my slides, but I just wanted to say that I will be giving a bit of a global perspective. So a lot of what I'm sharing is not necessarily appropriate, let's say, for the context of Ireland. But I think it will give you a bit of a background as to some of the things you need to think about as you're preparing your preparedness plan, some of the risks and some of the resources that are available from different agencies and some of the experiences globally as well. So I wanted to start by just giving a bit of a quick update of where we are in terms of child malnutrition, because I think a lot of people, it gets a lot of bad press, it's all doom and gloom, but in fact we are making historic progress in nutrition. So you can see here from these slides that we have had a significant reduction in stunting. It's declined by about a third since in the last 2 decades, since 2000, which means we have 55 million fewer children stunted, children under 5, than we had 20 years ago. And we've also seen significant progress on breastfeeding. We're going to talk a lot more about that today, obviously. So I think we all need to remain optimistic that progress is happening at scale and in many different contexts. Where we're a bit more concerned about is a bit of stagnation on some other indicators affecting child nutrition, particularly wasting, which are very thin children. Those numbers have stagnated a bit. We are seeing a bit of progress, but not to the extent that we need. And of course, with the frequent shocks and crises, it's hard to keep those numbers from spiraling out of control. And I think not surprising to anybody, we're also seeing increases in the numbers of children who are overweight and obese, which are other risks to health going forward. Speaking more in depth about breastfeeding, this analysis is provided by UNICEF. We have global databases on infant and young child feeding indicators, and you can just Google UNICEF nutrition data, IYCF data, and you'll have access to all that information. So we do monitor key indicators in line with the expectations of the World Health Assembly targets and also the SDGs. And we use national surveys, the multiple indicators cluster surveys, or the demographic health surveys, or other household surveys that give us nationally representative data. And then we consolidate them into the different regions. So this shows you in the different regions around the world where we are making progress and where we're making less progress. The green bar is where we are looking at early initiation of breastfeeding within the first hour of life. And then, of course, exclusive breastfeeding is up to 6 months of age. And this just shows you across regions that some regions are doing much better than others, and that some regions, there's a lot more work to do for sure. However, again, as mentioned, we are seeing progress. In fact, we have made significant progress in the last 10 years. We have increased globally the rates of, we as in the collective, everybody working in these contexts and governments, increased the collective rates of exclusive breastfeeding by 10 percentage points, which is significant. So up from 38% to 48%. The World Health Assembly target is 50% by 2025. So we actually are feeling optimistic that we will achieve that, that target. So what again it shows us is that when women are given the support and the counselling, and when they are protected against aggressive marketing and promotion by the industry, breastfeeding rates do increase, because this is the choice of many women. And we do need to feel positive about that and know that this is something that we need to remain committed to, because we are seeing progress. We also know that in countries that have legislation to protect against the aggressive promotion and marketing of breast milk substitutes, we also see higher rates of exclusive breastfeeding. And that also includes countries that have family-friendly policies like maternity protection, breastfeeding breaks, etc. So work on protection, promotion and support really does achieve results. And when women are supported, we do see these results go up. No data in there for Ireland yet, but we're hoping we'll have that soon. I understand that we should be getting some data soon enough on breastfeeding rates. So we look forward to representing Ireland in future graphs. Right, so let's now talk a bit about today's subject, which is in infant feeding in emergencies. So I think it's important first to talk a little bit about what do we mean by an emergency. And an emergency can be an event or a series of events that represents a critical threat to the health, safety and security and well-being of a community across a wide range of areas and population. It can be a natural emergency like an earthquake, a drought, a flood, health-related epidemic, COVID, Ebola, or man-made like conflict, nuclear explosion, etc. It can be sudden, can be protracted. And obviously all of those types of emergencies can bring different risks to populations. Now, normally in more developed nations, wealthier nations like Ireland, the response would be led by the government and obviously supported by the national or by the local community. But where the resources are less available and where the needs are very high, then international support is required. We would call that a humanitarian emergency. So humanitarian emergencies do not always occur in communities that are exposed to a shock. But infant genital feeding in emergencies is relevant in all contexts, whether it's just an emergency or a humanitarian emergency, as the risks to infants and young children and their nutrition remain, and they need to be supported. Infants and young children are the most vulnerable in emergency, and that's a pretty dramatic photo that I have there on the right. And of course, that's not always the case. But even in healthy populations, child mortality and crude mortality of the broader population and morbidity can increase significantly in a very short time frame, in up to 2 weeks. And in emergencies, apologies, there's some interference on the line. In emergencies, rates of child mortality can increase by 2 to 70 times. So it can be very dramatic, particularly in vulnerable populations. So we need to be really prepared to have our IYCF-E preparedness plans in place so that when a shock does hit, we can immediately respond and protect children from being exposed to these risks and from the risks in emergency contexts. Breastfeeding is a lifeline. It really can make the difference between life and death. Apologies, Liz, I think there's some interference on the line. If somebody can be muted, thank you. Breastfeeding provides a safe, nutritious, and accessible food source, a powerful line of defense against diseases, and can act as an infant's first vaccine, protecting them from the common childhood illnesses that they can be exposed to in emergencies, can be exacerbated, such as diarrhea and respiratory distress. So you can see here an extraordinary photo that was taken a long time ago in Kosovo, and now where we have this mother and her daughter who is doing very well. And it just shows you that women are extraordinary in these circumstances, and if they are given the right protection, that they really can be able to support their children if they are given all the support needed. So therefore, what is infant feeding in emergencies? It's about the promotion, protection and support of breastfeeding as a priority intervention. As we've just spoken about, exclusive breastfeeding for the first 6 months of life is the most effective child survival intervention. There's no debate on that. However, it also means that all children, we're not just talking about breastfed infants, and young children have safe and appropriate nutrition, which means ensuring safe feeding children in populations where they are predominantly formula fed. And I'm going to talk a little bit about Ukraine later on in the presentation. But it's also important that we consider the needs of caregivers, because unless caregivers are supported, unless their needs are met, they will not be able to care for and feed their children in the way that they would desire. Now, I'm sure many or most of you online are familiar with this book here. It's called The Operational Guidance for Emergency Relief Staff and Program Managers for Infant and Young Child Feeding in Emergencies. And this really is the Bible of infant feeding in emergencies and is regularly updated in line with new emerging evidence and experience. This is available in many, many languages, and there's a video here as well, but I'll talk a bit more about the operational guidance in the coming slides. So as mentioned, when we're talking about breastfeeding, we want to talk about protecting breastfeeding, and that's really by making sure that donations are not received or are just distributed unsafely, that laws are in place to protect against the harmful marketing and promotion of breast milk substitutes, and that the information that women receive on how to care for their children is not biased or affected by conflict of interest from the industry. And that's really supported by having national code laws in place in the government that can protect against undue influence. Promotion obviously is through counselling and through sharing information. And then support is really more at an individual level. It's identifying those mothers who have particular needs, who need skilled lactation support, those particularly vulnerable infants, such as newborn premature infants, other babies who may have feeding challenges, and making sure that that mother gets the support that she needs. So there is a difference between infant young child feeding in our terms of our routine programming, and then of course what that means in an emergency context. So in terms of our routine programming, we need to be protecting, promoting and supporting optimal infant young child feeding practices in all contexts, and improving where we are in our baseline. In an emergencies then, it's much more about doing no harm, immediately life-saving, and putting in place systems to support those particularly vulnerable mothers and infants. It's about saving lives, both those that are breastfed and non-breastfed, and where possible, improving the key infant young child feeding practices. Again, preparedness is key. You see this popping up, and this is why having such a plan that is being discussed today is so vital to the response and to mitigating against any risks, and really making sure that we give our population what they deserve and need. So what kind of interventions can we think about when it comes to infant young child feeding? Kind of at an individual level, and that's down at the bottom, we have counselling. And of course, counselling, and a lot of you online are much more expert than I on this, is not just about giving information. It's about identifying the particular barriers that a mother is facing and giving her specific support and counselling for however long she needs to overcome that barrier. And that's very much at an individual level. But of course, the further you move up here in this illustration, it's much more about community level and national level. It's about the enabling environment, the policies, and it's about the broader advocacy and communication, all of which will reduce barriers and improve the breastfeeding rates through the protection, promotion, and support to infant young child feeding and breastfeeding. We have, as mentioned earlier, we have this fantastic reference guide, the operational guidance for infant and young child feeding in emergencies. And I'll show you a timeline just now, but this was endorsed in a World Health Assembly resolution in 2010. So this really is crucial and a crucial reference tool for all countries to refer to as they're preparing the preparedness plan. And last year, a 10-year progress report was released. It was commissioned at the beginning of COVID and then got delayed, but it did get released last year. And it's a really, really interesting report, and it shows how we are doing globally in aspects of infant young child feeding emergencies. So I'm just going to share a couple of data points from there. And this is a nice illustration. It shows you the timeline of IYCF-E. Of course, many of you are familiar with the code of the International Code of Marketing of Breast Milk Substitutes, which was passed by the World Health Assembly in 1980. one, and subsequently there's been a number of World Health Assembly resolutions because in order to update in line with the industry behaviors and practices. But that was the first big global instrument that helped us identify what the risks are to infant feeding and to help governments put in place legislation and regulations to protect. You'll see a whole series of milestones and international tools, human rights tools that have come out since, obviously the Convention on the Rights of the Child, moving up to the BFHI, subsequent code resolutions. But then in 2010, if you look at the little bubble on 2010, World Health Assembly Resolution 63.23, which was an addendum to the operational guidance for infant and child feeding in emergencies, version 2.1. So this is really where it became enshrined as a core reference tool for governments to use as they're looking at preparedness plans. And then, of course, it's been updated on a number of occasions since then, and now it's available in a number of languages, and it has been used as a core document for many countries in preparing their preparedness plan. So this gives you an idea of other milestones on that timeline. So some of the slides I just want to show, they're all in the report, so you can have a look. It's easily available. NutriDash is an online database that UNICEF hosts in our headquarters. We are program countries. We have about 150 countries where we get data from. And every year we get updates on core indicators around policies, around programming, and we include infant and child feeding and in emergencies as one of the questions that we do ask on an annual basis to our country teams and our national government counterparts. These obviously are government policies. These are not just UNICEF, these are owned by governments. And one of the questions we ask is how many countries have an IYCF-E policy, strategy, or plan of action? And from 2020, this shows you that many do, in fact, particularly across Asia, across sub-Saharan Africa and Central and South America. It's a bit grey in many other parts of the world. And again, we look forward to having Ireland as an outlier there in the coming year or so. Again, another question was asked about infant and young child feeding, who have gotten it. This is more about kind of operationalization of it, the presence of a policy, strategy, or action plan, and funding for salaries. So again, this looks at the countries where they have and haven't. And of course, what you'll notice here is that the countries who are doing better are the countries who are more likely to face frequent emergencies, where there has been a lot of international support and where governments have prioritized infant and young child feeding in emergencies. So those countries that tend to be exposed over and over again to shocks tend to be a lot more familiar with the risks and put in place these measures to protect their populations. And then finally, the overall score for the infant and young child feeding in emergencies indicator, and this is from WIBTI, the World Breastfeeding Trends. And again, the information is getting closer to Ireland, but I am looking forward to, I understand there will be a data point for Ireland soon. And this just shows you how well countries are doing or not. And again, a mixed bag, but of course, better coverage in countries in sub-Saharan Africa as well, where there tends to be more technical assistance, more exposure to risks, and more familiarity with some of the issues. So the recommendations that came from that report were that member states, governments, should fulfill their commitments under the World Health Assembly resolution, as mentioned earlier, 62.23, and ensure that national and international preparedness plans and emergency responses include the actions outlined in the operational guidance and are funded. Of course, you can have everything nice in writing, but unless it's funded, implemented, monitored, then it's no good. They also recommend to strengthen emergency response by addressing governance and capacity gaps between the different structures. And this is often what happens in emergencies, is that the coordination may be with a different department and not with the technical people in the Ministry of Health or in the nutrition department, so that the risks, particularly to infant feeding, are not recognized. So it's important that those connections are made in advance and that those coordination structures are established. That awareness raising, training, institutionalizing capacity are invested in, and again, that we have a core cohort of colleagues and staff and volunteers and health staff that really have experience on some of the risks and some of the issues in terms of referring, that we're promoting and funding the interventions, that we're closing the data gaps. You would have seen alone from those maps that we don't have data from everywhere, but it's important to know, because data talks and data doesn't talk. If data is not there, it's not a priority. However, if we have data that highlights risks, that highlight gaps in our policies, we're much more likely then to be able to make the changes and have investments and changes. And then, of course, as a fundamental priority, continue to invest in implementing the code, including monitoring code violations, and adopt legislation to prevent BMS donations in emergencies. And of course, when I refer to the code, I mean all the subsequent resolutions as well. And we did have a delegation from Ireland at Code Congress this year in Geneva, and I think it was very successful in re-energizing, revitalizing commitment and recognizing the continuing risks placed by the industry in the protection of breastfeeding. So we cannot underestimate the importance of the code. Some of the resources that are available are, number one, is that we do need to identify who are the most at-risk groups. Now, again, all of you online will know this better than I, but those particular population groups that are most at risk are the youngest, the premature, the little babies with growth failure, where we have multiples, twins, triplets, sick, malnourished, etc. So making sure that those mums and babies are identified as a priority 1 and given the support they need. Then we also need our priority 2, which are groups at risk. And again, younger infants, first-time mums, adolescent mums, where there's health issues, so that they are identified as priority 2. And then, of course, everybody else is a priority 3. There is this lovely resource, the Operational Guidance on Breastfeeding Counselling in Emergencies, which was released about 2 years ago, funded by Irish Aid. And this is a really nice resource that goes through some of the very practical parts of how you can go about providing that counselling in emergency contexts. Where do we give breastfeeding support? Of course, this is an extreme situation. These are where we have displacements, but this can also be in a health facility, in a school, in any kind of a resource, a community centre. I think we just cannot underestimate the need for that one-to-one counselling support for mums who are facing difficulties. So it needs to be a space that's relaxing, that's conducive to receiving the counselling that a mother may need, and services for hygienic feeding of children, and again, information on where to access other services like antenatal care, like childcare if there's a need for immunization, etc. So having these safe spaces in any emergency context and making it relevant for the context, so whatever works in the Irish context, is really, really essential. And also having a space where mums can come together and support each other. And then, of course, for those infants that are formula fed, explore in priority order the viability of relactation or wet nursing and donor breast milk, again, in line with the preference of the mother. And then, of course, if not acceptable or feasible, then provide an appropriate breast milk substitute along with the package of support. It's not just the formula, it's everything around that formula. And again, that will depend on the individual needs of that household, of that family, but that they are given what they require. We do have resources for this, and these are some very nice infographics that are also generated and funded through the Emergency Nutrition Network and the Infant Feeding and Emergencies Core Group. They're available in a number of different languages. And they talk about planning and managing artificial feeding and supporting infant feeding, infants dependent on artificial feeding. These are all available for free online. And then just to advise that a couple of years ago, 3 years ago, UNICEF updated our procurement guidance, our guidance on the use of breast milk substitutes in humanitarian emergencies. It used to be that UNICEF was the agency of last resort to procure breast milk substitutes in emergencies, but that was identified as a risk, and that some infants who did not have access to breast milk were falling through the cracks. So we did update our guidance, and a lot of that also became during the Ebola outbreak in Africa, where obviously the risk to exposure to Ebola virus meant that children should not be breastfed. So UNICEF did step in and procure infant formula. So we now have our guidance on the procurement of BMS in humanitarian settings, and we have in a number of humanitarian emergencies have actually procured, but we do have very strict criteria working with the government, ensuring no spillage into the market, ensuring the right support and counselling and additional resources are given to the caregivers in such a context. I wanted to talk about the example of Ukraine, and one of the key actions that are recommended in emergencies is to issue a joint statement. There is a generic, a very nice format for one that was developed by the operational in the operational guidance, We adopted it for Ukraine. We included maternal and child nutrition, and this I think it's translated into about 14 different languages. Jodine will remember, I see Jodine online, this was one of the first actions that we did when the war started. It was important to have this joint statement, not just for within Ukraine, but also the neighboring countries where refugees were fleeing to be able to provide the support needed to those populations. That did include procuring formula. UNICEF did our best to procure ready-to-use infant formula, which is much preferred. Obviously, the risks of preparation are much more reduced, and then the caregiver just needs to give it directly to the infant. But it's sometimes very difficult to actually procure volumes that you do need. So you do need to procure powdered infant formula, and of course, then there are risks that the language, the description, depending on where you procure from, is not in line with what the population is used to. So we did produce a number of leaflets in different languages on how to use it. And it was issued within the guidelines within these safe areas with appropriate counselling provided as well. So these are the kind of resources that we do make available and that we do release during times of emergency. I wanted just to, before finishing up, just to talk about complementary feeding, because there's always a priority focus on infant feeding or breastfeeding or formula feeding in times of emergencies, but we can't forget that children also need nutritious food from the age of 6 months. That needs to be diverse and nutrient dense and balanced, and often that is neglected in emergency contexts. And even if it are exceptional times, we should not be feeding our children convenience ultra-processed food. So it's important to also consider the needs of complementary foods in times of emergencies. And just a reminder, children under 2 years, 6 to 23 months, have very tiny tummies. Every bite counts. All of these amazing physiological things are happening. Their brain is growing to 75% of adult size. More than 1 million new neurons are formed every second. Their height is increasing 75%. Their body weight quadruples. So we really need to think about the nutritional needs and making sure that children are accessing a healthy, balanced, diverse diet that is not high in sugar, salt, or unhealthy fats. These are some of the challenges that happens in emergencies. There's a lack of nutritious and fresh food. There's a lack of facilities. There's a distribution of ultra-processed food like dry noodles or dry soups. And there's an interruption of a routine which may interfere with the introduction of foods, meaning they could be introduced too soon or too late. Often there's less frequent feeding if populations are moving. There's a stress on the family, and in general, poor hygiene is a big issue in terms of lack of cleaning facilities, safe water, etc. So these are some of the kind of things that we think about in these programs. In general, food assistance, we adding specific foods that meet the needs of young children. Cash and vouchers are often a great option so that families can purchase, from the market, be it an egg, be it beans, be it fruit, vegetables. Nutrition sensitive food baskets to include foods that are appropriate for young children. In some cases where there are a lack of diverse diets, we can use supplements, micronutrient powders. Sometimes in some populations they do some wet feeding, there are camps, and then more kind of protracted emergencies, kitchen gardens, micro gardening, and then cooking and recipe demonstrations. These are some resources and some tools that we use in emergencies. Specifically for complementary feeding. The bottom two were two nice collaborations that UNICEF and ENN, the Emergency Nutrition Network, did in the last 2 years, where we basically profiled some best practice examples of complementary feeding in emergencies. So again, these are more for not necessarily for the context of Ireland, but useful resources for those that are interested. And this again shows you some examples of experiences of improving complementary feeding in the Rohingya refugee camps in Cox's Bazar, and then also in Brazil. And these are available on some links, and there's some podcasts. We had the same issue in Ukraine. We did release guidance. This was a bit of a struggle trying to find out what was available to young children. So we made sure to find out what are the norms of that population, what do they normally feed their children, and then making sure that we build that into the guidance for organizations supporting the feeding of children. Many organizations, very well-meaning, step up during times of crisis. So it's important to give them the information they need so that they can adequately support these populations, and not just think about kind of ultra-processed food. So in summary, what's really important is that emergency preparedness is critical to a timely, efficient and appropriate infant feeding and emergency response. That means we need to have policies, preparedness plans in place. People need to be trained. There needs to be a coordination system in place that can be mobilized so that there's no confusion over decision making. We need to assess and monitor our response. Clearly, these are multi-sectoral interventions. These include beyond nutrition. There's many other sectors involved. And we need to be clear that there are strong positions on not seeking or accepting donations by the government. So just in summary, again, we need to ensure our policy in place that's covering key provisions. We need to ensure our guideline is in place in line with the operational guidance, and that, very importantly, code violation monitoring and reporting system is available and is implemented and used. Comms and advocacy are super important so that it's not just talking to ourselves in an echo chamber, but actually we're talking to the general public. So this joint statement, I showed you the example from Ukraine earlier, a press release template is available that can be used. The government is very clear in its position on not accepting donations, and that core simple messages on infant and young child feeding and emergencies are easily available. So it's useful to have all of that in place that they can then be released depending on the context and the needs. There's a multitude of resources out there. The IFE core group is really the main group that provides resources and support to these emergencies. These are the partners, and there's a QR code here where you can access all the fantastic resources that are online. And you can also reach out for support through the ennet.org, where you can post a question, or the Global Nutrition Cluster, which is activated in humanitarian crisis. We have a technical alliance made up of expert partners who can provide technical support as needed for nutrition emergencies. The website is there. So thank you very much. And I just wanted to share some lovely resources that Mary shared with me that are available at leleshleagueinternational.org. You can see some of them there. And also we have a toolkit on the globalbreastfeedingcollective.org that has a whole series of really fantastic resources, some of which are appropriate for emergencies, but many of which are just routine. So I'll stop there. Thank you very much.
Thanks so much, Grania. That was really fantastic. I'm just going to open the room up for questions. And if anyone in the room has a question, Aileen might pop over and turn the mic on for me. I may start myself actually while somebody is having a little think. It was great to see kind of the graph that you showed of the various countries that have kind of some preparedness plan in place, and it's those places that have, you know, repeated experience of emergencies happening. In your experience, Grania, is within those countries, is there kind of a sole person who's responsible for, you know, monitoring IYCF-E or kind of delivering on the plan? I guess my concern in Ireland is, you know, this might get landed on the desk of somebody who already has a full workload. So I'm curious to see how this functions in countries that have, you know, plans in place.
Thanks so much, and also thanks so much to Jodine. She's acted as my support, who of course was the chair of the IP core group. So thanks, Jodine, for posting all those important links. That's a great question. In fact, in many of these countries, IYCF-E is actually a major priority, and you even have ministers of health who would take that on as a priority issue, because a lot of these countries have seen the impacts of crisis and have seen the impact on infant feeding and, you know, risk to children. So it's a very well-known entity, and because it's an indicator, breastfeeding and other indicators around infant and young child feeding are regularly reported on in nutrition surveys, it's constantly in the mind of the population. It does get priority. So no, it would not just be down to one person. It would be very much seen as a priority for the Minister of Health, and also in many countries with the disaster emergency team, whoever that may be. Often within their preparedness plans, indicators on IYCF-E would be core. So it doesn't tend to be a challenge. What we find, particularly in UNICEF, and I'm sure Jodine and others online can share experiences, it's more in the high-income countries where we have challenges. In many of the low and middle-income countries, it's a given. Everybody knows these are the risks. You put in place your plans, and you know, you have a lot of staff that are already trained. It's really more about mobilizing and making sure we're resourced to actually implement what is needed, and recognizing the specific needs of whatever that shock might be. High-income countries is very different because you have different issues. even when population are moving, like what happened in Ukraine, this was a whole new learning for all of us. It was like, what do we do with these populations? How do you support breastfeeding when a mom is in, in a bunker, there's shelling in Kiev? So you really, really need to think about adapting your programs to be fit for context. So I think there is a lot more learning also with the migrant and the refugee crisis into Southern Europe. There's been a lot more learning in the last kind of 10 years, I would say, on this area. But definitely high income countries need to do a lot more on this area because people are less familiar and less aware of the risks to infants.
Great. Thanks so much, Grania. If we have no questions in the room, I may just finish with one quick question there from Elaine Campbell, who's an IBCLC based in the Republic of Ireland. And Elaine comments on kind of counselling being really important, but we need to have translation services in place. And Elaine's wondering, kind of in your experience, how do other countries manage that?
Yeah, well, as mentioned, a lot of the resources that we have, because this has been going on for many years with the Operation Guidance, it's translated into so many languages already. With the Ukraine response, again, we were able to translate the resources we had quite quickly into Russian and Ukrainian and all and many languages. I mean, basically, depending on the population, the community you're in, or the population you're in many of these settings, the resources will be available in other languages, or you'll use the national staff who, because in some of these countries, like for example in Kenya, there are 42 different languages. So you will use staff from those particular areas, those communities, to actually communicate. You may not have all your resources translated into all languages, but you have to draw on what is known, the expertise within those communities, because they know best how to communicate to those populations. So your resources will be in the main languages, and I would say in many of the countries we operate in, that's already there. But it's absolutely essential that interpretation and translations into the local context as well as the language, so that you're talking about foods that are available locally, you're talking about practices that are practiced, you're talking about the context of that population, so that it's not a generic one size fits all, but it's really adapted to context. And that goes back to your preparedness plan. That should be the place where you identify what is needed for your population. And if translations are needed, which is now, Ireland's a lot more diverse than it used to be, translations definitely would be needed, interpretations in different languages would be needed. So that should be identified in the preparedness plan.
Yeah, we just have a question from the room. Aileen's just going to turn on the mic.
Yeah. Just wanted to make a comment about, if and when artificial baby milks are dispersed to a population where maybe some babies have not been breastfed, are we not beholden to also provide clean water and a method of boiling that water and storing in refrigeration? Myself and some of my HEA colleagues were in a camp in Greek island of Chios in 2016, where the Syrian refugees were arriving, war refugees coming off boats after horrendous journeys and so on. And we were absolutely horrified to find great big cans of dried baby formula in the tents, with no way of boiling water, no way of refrigeration, no way of cleaning bottles. And the best that we could do in that circumstance was throw away those tins and replace them with ready-made bottles of formula with a teat per bottle per feed, and then remove all those the next day to try and prevent infection somehow or another. So is there, we'll say when companies or groups are dispersing artificial baby milks, are they also going to provide the clean water or generators or some method of boiling water?
Thank you. That's a great question. And I mean, firstly, we should never allow donations. That's actually a code violation by any companies in times of emergencies. And in fact, in our procurement guidance for UNICEF, our priority product to procure is ready-to-use infant formula. So it's the pre-made, because taking into account those risks, powdered infant formula should only ever be used in a context where safe preparation can be supported, and that counselling can be provided, and that the information is provided in the right language, and that, as you say, clean water is provided and the necessary tools for cleaning feeding devices. So 100% agree. The distribution of powdered infant formula is just a nightmare in emergencies, and we really need to make sure And that's why donations are not, they're a code violation for that very reason, that it really puts children's lives at risk. We do recognise that there are infants that don't have access to breast milk that need access to infant formula. And for sure, in infants under 6 months, formula is the only recommended alternative. So their needs have to be met. But ideally, as you say, it should be ready to use infant formula unless those conditions around safe preparation can be provided. So fully agree with you. Yeah, that's the minimum.
Great. Thank you. Thank you so much for joining us, Grania. We will have to move on now, but if anybody has any questions, please pop them into the chat box and we will do our best to get to them as the day goes on. Thank you very much for joining us, Grania. If you can stay, we'd love to have you, but we understand you're a busy woman with a lot going on. So again, we really appreciate and value your input. So thank you very much.
Thanks so much, Liz. And I'll give you my presentation so people feel free to use it if it's useful. Thank you so much.
Fantastic. Thank you so much.
Bye-bye.
Bye, Grania. Thank you. Okay, so we're going to move on to our second speaker of the morning session, which is my wonderful colleague, Dr. Aileen Kennedy. Aileen is a dietitian and lecturer in dietetics at TU Dublin. She completed her PhD on breastfeeding and the development of taste in infants, and since then has continued to work in the field of infant and young child feeding with a specific interest in the feeding of premature babies. She's currently the chair of the Research Steering Committee of the Irish Nutrition and Dietetics Institute, and we're of course delighted to have one of the co-PIs of the project here to present some of our earlier work in this area. We just have a quick question from the room. Yeah, Helen?
Could you just clarify whether you can take photos of your presentation and
Yeah,
whether you're happy for that?
Aileen is going to say that at the start of her piece. Yeah, thank you so much.
We're on that, but thank you, Helen, for reminding me. Let me get some slides up here. So this presentation is just to really give you a bit of a background to the project and how it came about. So the data I'm presenting here is actually under final review for publication. So hopefully in the next few weeks it will be published. So we are happy for you to share any pictures and slides of it. And just remember that the hashtag is IYCF-E Ireland, all one word. I have to say that quickly or I don't get it right. And if anyone's on Twitter or any other social media, to use that hashtag. Thank you. Won't go into a lot of the detail because I think it's been covered very well by Grania already. Sorry, don't want to do that. To get rid of all these. But just thinking about it, emergency situations, so we need that to have appropriate evidence-based and timely support for infant and young child feeding. It saves lives, it protects child nutrition, health and development, and benefits mothers and families. And as we've already all know in the room and online, and we've seen it from Grania's presentation, that there is clear guidance that every country should have a plan. And unfortunately, most of what we call the global north wouldn't have that plan as of yet. And we're hoping by the end of this project that we will have that draft plan. And I guess for us, then we are really thinking about the vulnerability of that age group of 0 to 2 years. We know that the impact of food preferences and nutrition and intake during that first 1,000 days of life, let's say from conception to year 2, will have a major impact, not only in the short term, but over the life cycle of that individual and maybe even intergenerational. So we know that, you know, not having good nutrition during those early weeks, months, years could actually expose them to infection, illness, potential death, but also long-term consequences as well. And we're all, you know, very clear that breastfeeding is the safest way to feed infants, particularly in that emergency situation where we cannot guarantee that any artificial food that is given will be safe due to hygiene reasons and other things. But emergencies will create unique challenges for families. And it's not just as simple as just saying, well, let's just feed a baby, just breastfeed. You know, many babies will come into that emergency not having had ever breastfed. So we have to deal with that. We will also deal with trauma and stress, and it's not as easy just to leave that responsibility to those parents. We must support families in order for them to be successful in their breastfeeding or infant feeding journeys. So we need to make sure that there's safe feeding and preparation of both breast milk, complementary foods, infant formula, in order to minimize morbidity risks. And with that situation, I think we know for many of us in the global north, we have always thought of that as a global south problem. And with the changes that have happened, and I think probably COVID for us has been a very large wake-up call that it is relevant for anywhere, in any context, in any part of the world. So that's kind of where our project came from. And I guess more personally, this is where it came from. So during the lockdown of 2020, both myself and Liz were having conversations. We were both feeding young children ourselves, and we were kind of seeing that particularly across social media, and people talking about particularly around infant formula shortages. And although we're both interested in breastfeeding, the conversation around this started around infant formula. And we were like, are the shortages just people talking online and scaremongering, or is that an actual problem? We all know the rush for toilet paper, and you saw that. But you also saw that response from supermarkets, retailers, government assuring people that nobody was going to run out of toilet paper. But we didn't see that same response when it came to infant feeding. So parents were saying this online, and we wanted to know what was the problem as well. Subsequently, you know, we've had some flooding, we've had storms, we've had Brexit, we've had issues around supply chains, you know, coming up to Brexit and around the time of Brexit being implemented, we had that, you know, what ifs, what will happen, will it all fall apart? So a lot of things were happening around those times, and it was myself and Liz having those conversations. So we decided then to go out and to actually ask those questions. And just to give a little bit of context for those that maybe are from an international point of view, Ireland doesn't do very well when it comes to breastfeeding rates. We've got one of the lowest in the OECD countries. So the data we've had for 2019 and 2020 within the Republic of Ireland, the numbers of babies breastfed at first feed following birth, we've got it around 63%. At discharge, which is, you know, 2 or 3 days later often, exclusively breastfed, we're less than 40%, so we're 37, 36%, and very similar rates in Northern Ireland as well from their data as well. So we are not doing very well supporting parents and families on breastfeeding. And so we need to think about that. And we do come, unfortunately, very much from a culture of artificial or breast milk substitute feeding or formula feeding in this country. And so if that is what normal support looks like, what would happen in an emergency when we need to be able to support people even more? And if we can't get it right during, I don't want to say normal times, but on regular times and on a day-to-day, we're going to have even more issues when it comes to emergencies. So we decided to go out and actually figure out what was happening during that period of time. So it was around the period of time where we were still having a very strict lockdown, where you were only allowed go 2 to 5 kilometers outside your area. You were asked to stay home. Everything was shut down. And we surveyed it around the month of May. So from the beginning of May to the end of May in 2020, we received 770 responses. It was now, in fairness, only limited to the Republic of Ireland. So this data doesn't reflect Northern Ireland, but I think they had a very similar probably response. And it was any adult with a child under the age of 2 that could respond to that. And what we found, I guess, like all online and research, we do recognize that it isn't very much similar to the population. You can see straight away that we have 94% of individuals having a 3rd level education, and most of them were married or had a partner, and most of them, so half of them or more than half of them, were on maternity leave or working from home as well. And we had very small numbers, so only about 5 or 6% of those having a medical card. So we know that the kind of SES status of these were probably quite higher. But what we're kind of saying is, if these people are struggling, then what are we talking about? People that we maybe didn't get to have access to as well. So we had a very high rate of those individuals that were breastfeeding. So I guess about 80% of the sample had breastfed or fed breast milk during the COVID crisis. And about more than a quarter of them said that they had changed their practices because of COVID. So it was impacting people. And I like this quote: "I introduced formula earlier than I would have liked to give me some rest, given that I'm now teacher to 2 other children, housekeeper, cleaner, while having a newborn. I feed in more uncomfortable positions. I don't have the time to enjoy the experience, e.g. sit at the kitchen table while doing schoolwork and breastfeeding, holding the baby in a position that hurts my back." And why I said I like that, it's not an image that I like, but I think it was reflective of many mothers and families trying to juggle maybe working at home, educating children at home, homeschooling, entertaining kids at the same time, and trying to maybe even then deal with a newborn as well. So it was very difficult circumstances, but still they were within the safety of their own home as well. So think about the added difficulty if you were in an emergency as well, and maybe having to leave what you know is home as well. So we asked them then, we gave them a list of challenges that we thought they may have. About 41% of them said they had no challenges, but majority, or still a large percentage of these individuals, said that they weren't able to access breastfeeding support, whether that was in-person, one-to-one breastfeeding assistance or support. And you think about during the first part of lockdown, there was a lot of people, we hadn't time to maybe move things online. We were still setting those kind of services up. So everything was having to kind of shut down in emergency and then start to move and take time. So maybe by, 2021, we might have had these things up and running more consistently across areas. But this was kind of during the first period of lockdown. We also had people concerned about decrease in supply, other people saying they were being encouraged to stop breastfeeding as well. And some of them were, concerned about maybe food shortages and other kind of difficulties as well. But they wanted support. And we asked them then where were they getting their information? So if they weren't able to access support, where were they going to? And again, a lot of them were heading on to social media and volunteer support groups. And maybe those volunteer support groups were faster in being able to, they probably didn't have the same bureaucracy, and they were able to move and change more quickly than maybe some more of our health services and things like that. So they were still going luckily to volunteer support groups to try and be able to get that support. But, still vast majority were going onto social media. And we know that once anyone goes onto social media, you don't know exactly what they're getting, because it depends on what social media they're getting, if it's an influencer or actually someone that is qualified to give that support. We then asked the question, and we took a little bit of qualitative data around this. Is there anything that would have made your experience with breastfeeding easier during COVID-19? And really, it was kind of 2 main themes that came out from those questions. We were talking about support and information. And there was kind of 2 different kind of things. They wanted any support. They wanted face-to-face support, but in the absence of that, they would have taken anything. They would have taken online support. They really wanted home visits. They wanted that practicality, but also they wanted consistent information. And we found that particularly of those maybe people that had established breastfeeding, they were like, well, what happens if mum gets sick? What happens if I have to go into hospital and baby is at home? How am I going to juggle that? How am I going to breastfeed? How am I going to be able to get that breast milk to my infants? Increase awareness about the supports available. So, if I'm not able to go to the hospital, or if I'm not able to go to my local group or whatever, where are the new support systems? Where are they? If they've moved online, I want information about it. And that's what we were finding as well. So we had a couple of quotes here. So if the public health clinic support group could have moved online rather than going on a hiatus, it would have been made my experience easier. I understand the public health nurses were massively overworked at the moment, so I'm not annoyed or anything. So they understood, and they were very kind of concerned and understanding of staff and their difficulties they were having, but they were kind of going, well, you know, they just weren't there. Another quote, I'm very well established feeding now, but it would have been very difficult at the beginning without physical support of a lactation consultant who had to visit on a few occasions until the baby was about 8 weeks old. This one, I think if there was information given about what would happen if I was in hospital, could my baby stay with me? If not, could someone collect my pumped milk? It would have been a relief and caused less worry. And lactation specialists being allowed to visit the house. Advice that remotely is of little assistance for such a hands-on thing. So they were really trying to want and needed support and really know what to do in the case of a crisis as well. We also asked those individuals, so it was about infant feeding, it wasn't just exclusively breastfeeding, what was their challenges and what would they, so we have about 31% of the sample that are feeding infant formula to their infants during this period of time. And they were really about kind of more strategic and problems, being afraid that there was going to be a shortage. So about 60%, so nearly 2/3 of people that were being in this survey that was giving infant formula were afraid there was going to be shortages. They purchased extra, so nearly half of them purchased that because of the fear perhaps, and maybe that was causing shortages locally. So although the supply was probably stable, there probably wasn't any issues. And so from maybe a government and strategic level, they weren't concerned about it, but parents were. And then, you're on maybe social media, you're hearing about so-and-so couldn't get their brand of formula, they couldn't get, it in their local shop. We were told to shop local. We were told to not go past 2 kilometers or 5 kilometers. So it wasn't like you wanted to go to multiple shops. You might have to queue to get into the supermarket, or you're getting your shopping delivered online and you're not being able to then get substitute if that formula isn't in that shop that you've asked for your online shopping to be. But we did find that nearly 1/3, so 29.6% said they had been unable to purchase formula due to shortages. Now, that might just be in one shop. It might be that they've gone to a different shop, they could have got it. But we were seeing what we were getting reports anecdotally on social media was coming through in our research as well. Again, we asked what would make your experience easier. And they were saying, well, without a public health nurse, it's difficult to get unbiased information on partially weaning from breast to formula. So if I wanted to continue or change, that was difficult. We do online shopping, but at the start of the pandemic, they weren't doing substitutions for formula, and I was worried we'd run out. If they'd been able to guarantee stock, it would have been less stressful. Less panic buying or talking about panic buying. And knowing for sure that there wouldn't be a shortage of supply, and then being frightened by social media showing people stocking up and shops being without formula. So again, what people were experiencing was probably leading to some shortages as well. And that was something that probably needed to have some clear information on in order to create crisis. So we then looked at, the survey was looking at all infants under the age of 2, but then we wanted to look at specifically those parents that had a baby during that period, so that period from March to May, to when the survey was happening. And we said to them, what were their challenges? So there was 142 new babies born during that period that was taking part in the survey. And again, very similar. They were having the same issues, access to breastfeeding supports, particularly in-person and one-to-one assistance, and really a lot of stress around decreasing in your milk supply as well. Again, they were going to kind of the same things, but again, they were moving towards, nearly 56, 57%, looking at social media. Public health nurses were coming out strongly at 41%, lactation consultants and IBLCs, 39%, and volunteer support groups. So a lot of people were relying on the usual people to provide some support for them, but also it was very high on the level of social media. We asked them the same question, what would have made their experience of feeding a newborn easier? And again, really this idea of support in hospitals, having their partners in hospitals postnatally to be able to help and get that information on board as well. The midwives support groups were coming out as really strong, and the public health nurses, and then friends and family were also being mentioned as well. We had, this was one kind of a quote, so if it were the same question, but the qualitative results here: contact from public health nurses to check in as all groups were cancelled, felt like I couldn't ring because they were being redeployed. Phoned the health centre where the community lactation consultant is based, and the person who answered the phone said they didn't have a clue what a lactation consultant was. So when you actually go and reach out and ring up the local health centre and someone says, well, I don't know what that is, I don't know how to help, you know, and this is a new mum. This is, you know, someone that's only having a few weeks old. We're talking about, you know, the max these could have been were probably like less than 12 weeks old. So this is a mum that's needing help, and this is the response they got. A better initial support via postpartum midwives in the hospitals. They were pushing formula, I guess, as they were overworked from the crisis. And more support in teaching in hospital on how to breastfeed. I found this to be non-existent. I had to teach myself how to feed after leaving hospital. I cannot overstate how little support I got with breastfeeding in hospital during the coronavirus crisis. So again, it's not a pretty picture. And then the minute we have a large crisis within the country, we see this lack of support happening for the most vulnerable infants in our society. We asked the same. So we had about 69 of these individuals that came under being newborn and formula feeding. And again, you know, nearly half of them said there was no challenges, but again, they were still afraid of the shortages. So they were afraid that there would be, nearly half of them were afraid that there would be shortages. A third of them nearly, so 29%, purchased extra formula, and 18% or 19% said they were unable to purchase formula due to shortages. Again, we asked where are they getting their information from, and again, they were really going to friends and family, which is probably normal given the culture that we live in. Infant formula website companies, so equal amount getting information from infant formula, and that's kind of scary that that's where they're going to for their unbiased information. And public health nurses had dropped down below that. So again, you know, we had over a third of them saying they're not looking for information, but others and midwives were below that even again. My own interests is looking at premature infants. So I have an ex-25-weeker who's just started school this year. So he's come through it very well. But I was, again, in a lot of kind of support groups talking about premature infants and what they were experiencing in hospital during that period of time. So this is a very small sample. There's only 19 individuals again. But again, overwhelmingly, they were still saying not having support, not having access to in-person support, one-to-one breastfeeding support, and stress about decreasing milk supply. And again, what was probably coming out with them was very similar. Is there anything that would have made their experience easier? Really, it was coming under unrestricted access. So there was a lot of access restrictions placed in some maternity hospitals. In the Republic of Ireland, you were given 15 minutes in the NICU and during that first period of time. And, you know, feeding, and you'll see it in the later slides, feeding was considered as visiting. So that was still your 15 minutes. And one person, I'm not sure I put the quote in, but one person described it as in the middle of feeding their baby, they were asked to leave because their 15 minutes was up. So that really came strongly out on all of our individuals that talked about the restriction on access. What would have made it easier? More regular and more time spent observing and educating on latch in hospital, immediate support via face-to-face contact on return to home, longer visiting hours, being listened to by hospital management on having feeding visits in COVID times, in-person lactation when we got home, midwife home visits, and in-person help and support. I needed help getting my baby to feed directly. Exclusive pumping is exhausting. And so that was what was coming out from those individuals as well. So when we take that results of what we were seeing, then we were kind of thinking, well, look, COVID showed us that infant feeding wasn't being prioritised within, well, we'll say within the Republic of Ireland here, and that both formula feeding families and breastfeeding families wanted more in-person support, and they wanted kind of reassurance around supply as well. Within the NICU and premature parents, that added restriction on visiting, and seeing that visiting was seen, or feeding was seen as visiting, was really strongly coming across. And we said, well, this is our first major crisis within this country, and we need to have a better plan for future crises. And that's really where we kind of took this project from. And then in May 20, so a year later, I guess at the same time, Northern Ireland was doing some focus groups, and they looked at what was happening. And this report came out in May 2021. And again, there was some positives, and we found this as well. Some people reported saying they valued the time and space. You know, they didn't have family members coming in. They weren't, you know, particularly newborns. They weren't having, you know, they had the space to just figure it out. And so it's same thing happened in Northern Ireland. You have people reporting that, and it helped to establish breastfeeding. A lot came across around the kind of blended approach. So not one, I guess, size fits all, that some people mightn't be able to come all the way back to the hospital. Maybe they're sick, maybe they're recovering from cesarean sections. So some people liked the blended approach, but I think everyone agreed, both the providers of the services and the mothers agreed, that nothing replaces face-to-face contact when mums are struggling and distressed. And so that face-to-face should always be there as a possibility. For maybe mums that are just wanting a bit of reassurance and they don't really have any issues, maybe just online is enough for them. But then when you are in crisis, when you are struggling, you need the face-to-face. They needed that practical support, particularly in the early days, and therefore it'd be important that a step down or reduction of home visits is a last resort, and it should be safeguarded. And that was happening the same in the Republic of Ireland, that was kind of the first thing that went, you know, rather than it being the last thing that goes. And there was also noted within the report as well, there was gaps in the provision in different areas. So there wasn't consistency of service across Northern Ireland as well. And they acknowledged that in the report as well. So I guess from that, then we kind of got together and said, well, what to do? And so this is really where we came to put this application in for the HEA North-South Research Programme. So myself and Liz came together initially, and then we reached out to Claire in Queens, now Leeds, and we kind of wanted her expertise to kind of think about the legislation point of things, and to talk about that and the human rights around breastfeeding as well. So we put in an application then at the end of 2021, and then we kind of put this project together with this application. So we have 5 work packages, and so you will hear a little bit about work package 1, which is our preliminary findings, and work package 2 from Claire in the afternoon and Samantha. And then we're also going to be working out some kind of mapping out of potential emergencies that are going to impact the island of Ireland in the context of infant feeding as well. And I guess the one we're all waiting for at the end of next year is hopefully having developed a draft infant and young child feeding and emergency preparedness plan. So I've said it out loud, now we're under the pressure. And we have a separate work package, which is really more internal reporting and project management, but also kind of dissemination. This is part of it, is trying to get the conversation going and having the likes of the experts here in the room talking and seeing what we're maybe missing or blinkered with. And so we love your input on that. Since putting that application in, and we kept texting each other going, God, it's more relevant, it's more relevant, it's even more relevant, because, you know, we've had the war in Ukraine has came about. We had crisis with, you know, supplies in different countries. We've had wildfires across Europe. We've had major storms in Ireland and knocking out electricity. We've had the formula crisis in the US, where they had to close a plant and there was low supplies. And we've also had a cost of living crisis, where it is now coming up that people just literally cannot afford formula. And it's not just easy to say, well, sure, breastfeeding's free, why don't they just do that? You know, you can't just simply do that without support. So we need to think about those kind of potential crises and how do we address those issues within the context of an infant and feeding plan for emergencies. We now have, I think Grania mentioned it, it's not just breastfeeding and infant feeding or formula feeding, it's also complementary feeding. We now have a generation of kids that have been born in emergency accommodation, living in hotels, hostels, that are going through their transition from milk and whether that's infant formula or breast milk, to solid foods, living in hotel rooms. And you can't prepare nutritious food, and that is going to affect their long-term health and development over the course of their life as well. So there is many issues that we need to address with it. So I think that's probably a good point to stop at, and I welcome any kind of suggestions or questions. And the next presentation will kind of talk about our first draft, our preliminary findings of the supports we are finding currently, and you can follow us on Twitter as well. Yes, Ray.
Aileen, thanks for a fantastic presentation. I'm glad you mentioned the cost of living crisis at the end. Do we have any insight into what's happening in food banks, whether mums that are breastfeeding get extra support in terms of nutritional support, or who's supplying breast milk substitutes to the food banks? Is there any biases there? Are we sure that there aren't any code violations within food banks? Because, you know, they're kind of sneaky, some of these folk that we have to manage and deal with.
Any of my experience is anecdotal here, so don't quote me on it. I know I'm being recorded. But there is probably a mixture. So I'm aware of several in the Republic of Ireland, and they're just given vouchers for them to go to a shop, or they'll go to the shop and purchase it on their behalf. When people are turning up, they usually don't stock it. But I'm not saying that if I went into a different food bank in Ireland, in the Republic, that wouldn't be there. I think most of them are aware of that, and there is a big debate happening, I guess, whether, you know, that should or shouldn't happen. I would agree it shouldn't be just provided like that. I think it creates more issues and problems, but it is something I think that is within Ireland. It is charities that are running those food banks. I think councils kind of have more control, a little bit more up here in Northern Ireland. I might be mistaken, but I think within Ireland we're reliant heavily outside of, let's say, the major urban areas on the St. Vincent de Paul, and even within the urban area is St. Vincent de Paul. And so, you know, they will get some funding from government, but they are kind of running charity services while we don't have the same input from like maybe a government run service.
Thanks, because, you know, I think this is a sort of an ongoing emergency, and certainly does fall under the remit of what we're trying to sort of, you know, the need we're trying to meet, and there's no sign of it changing anytime soon. The cohort that you had in terms of responding to your questionnaire were clearly not these mums, and actually they're a very significant proportion of the population, and proportionally they're where we could get most bang for our buck in terms of improving the outlook for mums, for families, and for young infants.
May I ask you to introduce yourself to the folks on Zoom?
Oh, sorry, my name is Ray Nethercutt. I'm the officer for Ireland for the Royal College of Paediatrics and Child Health.
Thank you very much. Yeah, I think you're very correct in it. I think it's something that we're not addressing well at the moment. And like I said at the very outset of this results, that like these are very well educated families that are probably very comfortable. Very few of them had lost their jobs through COVID, so they were probably quite middle class, working from home, and probably had a roof over their head, very comfortable, and they were struggling. So you can imagine those families that had lost their jobs, were being putting on COVID payments, were maybe struggling to make ends meet, who maybe don't have tenure or security of housing and all those additional issues and stress. And, you know, I think we kind of forget about trauma and stress and emergency, or we don't, but, you know, I think as researchers, we need to think about those and what the additional problems. So it can't just be an easy fix of saying, and I can understand why people say, well, why can't we just donate? You know, because that's the easy fix. Then we don't have to think about it. But when parents need support, the easy fix is not going to fix it for them. And we need to think about it in terms of that. Yeah. Just maybe turn the mic on there if you press the center button.
Aileen, thanks for that. I'm Tom Burke. I'm an acute paediatrician here in Belfast and at Queen's. We knew pretty early on in the pandemic that COVID wasn't making infants critically ill, but it was making them sick, and often sick enough to be admitted to hospital. Was there any sense from your parents about the increased importance of the immunological benefit of breastfeeding during a pandemic? And is that maybe something that could be reflected in your plan for future pandemic planning, that actually we need a massive upregulation of breastfeeding support?
Yeah, great question, Tom. When I went back and said about a third of people changed their practices, and I know I was trying to cut down on slides, but there was some other quotes where people were saying, well, I was about to give up breastfeeding. You know, I'd done it for 6-8 weeks, or I'd done it for 3 months, but I decided to keep it on because I heard about the immunological benefits of breast milk, and I just didn't want to take the risk of not having it, or if baby got sick, I'd have that as kind of a backup. So there definitely was an awareness within our participants that was going to be of benefit. But I agree with your point of needing to kind of think about that in a plan and think about sending that message out to people and making them aware of it, whether that's during antenatal care or, you know, while they're in maternity hospitals before they even leave, when they are making, because we know most people make that decision while they're still pregnant if they're going to feed. And if we're in the middle of a crisis and you can counsel women and support them and make them feel empowered that they are going to be able to do this, then I think that would be a major achievement and something that we hope to reflect in the plan.
Thanks, Aileen. That was brilliant. And I'm Siobhan Ward from the Lecture League, and my question follows on from Tom's a little bit. I think that there was lots of mothers out there who did choose to breastfeed because they knew it was so important this time, but they were so badly let down because they hadn't gone into this expecting to breastfeed, and then they hadn't got the support. So for them, it was, you know, such a difficult experience. And I'm looking at your figures that actually accessed online support and support groups. We in the Lecture League started Zoom meetings the day after, I think, the country locked down. So we really had that support there. And I'm shocked to see so few people knew about it. I'm wondering about those people who didn't answer the survey, the ones they would probably be more or less likely to have heard about groups. There's a huge problem with communication then, of getting that information out there. And is that something that we need to address big time?
I think so. And I won't steal Liz's thunder at her presentation. But I think it is like, you know, even just the simple thing about formula, like that was a crisis created by panic, you know. And I think what your point is that, yes, a lot of people did want to breastfeed and know about the benefits of the immune system around breast milk and maybe made those decisions. And if you've gone down that route and educated yourself around that and then not to succeed, that is a huge letdown. It's probably worse than, you know, maybe going, well, maybe I will breastfeed, maybe I won't. And I think, you know, that is really important in our communication piece. And I think it is something that we are going to have to think about very clearly, because you can see it within, let's say, a NICU scenario, like everyone tries to breastfeed, you know, and there's really high successful rates, you know, in that period, because they know the benefits, they know what it's going to be so important, you know. It's seen as medicine, it's seen as the one way you can connect with your infant. And, you know, even my own personal experience, you know, I was in hospital for several weeks before my baby arrived. And there was women on the ward that were like, oh, I'm never going to breastfeed. They were all in the same situation. But when it happened and they did have their baby early, you know, they were convinced, they wanted to do everything they could to protect that child. And if that was breast milk, then they were going to try, and some of them had great experiences, some of them didn't. But they all tried. And I think, if we could get that communication piece out on how important it is and communicate. But I think also people were saying, yes, there was online services. And I know La Leche League was very quick in turning it around and getting it online. But were people aware, like were the midwives aware of it in the hospitals to say, look, we can't provide it, or the public health nurses, were they aware that they were saying, well, we can't provide it, but we know the La Leche League has and here's the link. It's trying to get those messages out. That is a huge challenge. And for a volunteer organization, it's not like you have a paid communication officer or you've got RT and you can have a paid ad or whatever it is, and this is where a plan will help and government will help with that. I'm stealing your thunder as well. Yes. Yes. Okay. I think we have to leave it like that. We just have like a 2 or 3 minute break in order to allow a little movement. Feel free to do a few exercises, walk around. I was at a conference on Saturday. We all had to do exercises in heels every 10 minutes. Toilets are here to the left. If anyone needs, and there's tea and coffee out here to the right. And for our online guests, if you want to get up and make a cup of tea or something, that'd be great. So we might just get started. I know our colleagues online are. Okay, apologies, you're going to have to listen to me again, but Lorraine Tham, many of you have maybe spoken to her over the last few months, is unable to make today's presentation, but I'll have to say a huge thank you to her because she's collected all this data through all the interviews and has done all the analysis. So I'm just here presenting her work today. So this is part of the first work package that I mentioned about the project, and it's a preliminary analysis of this data that Lorraine has collected over the last few months, and it's looking at it from the perspective of healthcare professionals on infant and young child feeding support for families on the island of Ireland. So we've had engagement from both Republic of Ireland and from Northern Ireland as well. And what we're trying to do is kind of talk about, again, the availability and the accessibility of IYCF support from the perspective of healthcare professionals providing care to mothers, infants and young children on the island of Ireland. And because of that, we wanted to interview healthcare professionals involved in providing that support. So we really did our recruitment through professional connections, hopefully snowballing, and through social media, and we had expression of interest forms. I'll talk a little bit more about that. We've done a lot of interviews in the Republic of Ireland, less so in Northern Ireland, and I might encourage any of our Northern Ireland colleagues to spread the word at the end. But it was involving a semi-structured interview of healthcare professionals involved in IYC support, and then we are using Brown and Clark's reflective thematic analysis to look at that. And so what I will say to here is that this data here is quite new. It is only preliminary analysis, so we would be appreciative if this isn't tweeted and shared in that sense. So I'm just going to try and get rid of that. What we have is a range, and you can sort of see while we're well covered in Northern Ireland, in the Republic of Ireland, we're less so in Northern Ireland. We've had some midwives, public health nurses or health visitors. We've lactation consultants or infant feeding leagues. We have some private lactation consultants in the Republic of Ireland. We've got a neonatal speech and language therapist. We've got some GPs in both. Well, we've got 3 in the Republic of Ireland, only 1 in Northern Ireland. We've got a couple of neonatologists from the Republic of Ireland, an obstetrician, pediatric dietitians, medical social worker, public health professionals, and maternity and neonatal managers as well. So we've still a few gaps within Northern Ireland, particularly within the acute services. So we'd like some more interviews to be completed in Northern Ireland before we consider it kind of saturated in terms of data collection. But this is where we're kind of getting our information from, and the kind of professional qualifications that the healthcare professionals that took part are involved in. We've kind of developed, looking at all those semi-structured interviews, 2 main themes. One being the look factor. And, you know, probably some people could probably answer that question already, you know, where you are, assumptions by healthcare professionals on feeding choices, the kind of barriers to education and training for healthcare professionals, conflicting weaning guidelines. You know, some people will one doctor will say one thing and a nurse will say another, and somebody else will say something else. Confusion around safe formula feeding, a lot of lack of knowledge, and a lot of medicalization of infant feeding as well. And then the kind of the structural barriers to support infant and young child feeding, that the healthcare professionals feel. Time, burnout, and circumstances of birth. So again, you know, a lot of the things that we could be doing better to support our healthcare professionals that could actually support then our families. Then a lot around communication and critical connections, really. So empowering people, communication, how we introduce, you know, formula and artificial feeding, connections between healthcare professionals and volunteer and getting that word out. You know, if we're doing really well within the volunteer support groups, how are we getting that word out to mums and families as well? Building relationships, you know, so because so-and-so knows about something in the community, there should be referral pathways, and it comes up a lot as well. A lot of cross-border cooperation, cross-border services differences as well, disconnect within supports, and thinking about safety as well, and protecting that family unit. So they're the kind of themes that kind of came up, and we'll look at them a little bit more detail. So the look factor, that is the theme that represents how accessibility to appropriate infant and young child feeding support from healthcare professionals can be inconsistent. Therefore, families who access good support are considered lucky, according to the healthcare professionals. And so it was around 2 sub-themes from that developed as well. Chance encounters, so the quality of support was really impacted on what maybe how qualified or how interested that healthcare professional was that they encountered, and the circumstances and care. So again, it was like the individual circumstances of that family at need, you know, so again, needing to think about consistency across services. How do we ensure that that look factor is removed, that it's just normal services and it's just there and it's a given for everybody, and consistency across, not, you know, a postcode lottery or the availability of services because you're private or public medicine, particularly within maybe the Republic of Ireland as well. The other one then, like I said, is critical connections, and the description of that is really how the connections between healthcare professionals, other support organisations and family are critical for access to appropriate IYCF support. And that's really kind of thinking about it in terms of how those connections, if they're not working well during our regular working week or days, what's going to happen in an emergency? You know, how can we rely on those connections being well, you know, documented and continued if we don't have them in normal services? So again, 2 kind of sub-themes came out with that. Missing pieces, so the gaps in support systems and referral pathways have a negative impact on accessibility. So-and-so knows all the knowledge, but so-and-so isn't working that day. So what happens to that family when they come for support? And communication and collaboration. So communication between community support organisations and healthcare professionals to ensure that continuity of support as well. And then if we can build those networks and make those networks more visible for everybody that's working in the area of infant and young child feeding, then it will just be natural when, if there's an emergency, that those support systems are already in place and people are aware of them. So this is kind of the work from Lorraine and her interviews with healthcare professionals. So this is what really came out. It's like Russian roulette. You're dependent on what level of knowledge that nurse has. But again, you're relying on that knowledge of that particular dietitian. It depends on what hospital they're going to. Different advice off different people. And so if you're a new mum and you're getting different advice off different people, it can be confusing. Which doctor is the right doctor, or which healthcare professional is the right one? Who has the most knowledge? Which one I should follow? So again, really, it was the quality of support, and this was coming from healthcare professionals, said the quality of support a family receives depends on their individual healthcare professional a family encounters during their journey. So whether that healthcare professional had access to education and training to support infant and young child feeding. What was the resources at the time? Are they run off their feet? Do they have time to sit with that parent or family, or have, you know, an interpreter, or have whatever tools and resources they need to be able to complete their jobs as well? And a lot of it was around the capacity of healthcare professionals to always go above and beyond. And we saw lots of examples in those interviews of them doing that. And we acknowledge that they're doing it, but that done consistently. And I think we see that through COVID, there's burnout, there's loss of that, you know, there's people leaving the health service because they can't keep going above and beyond. And we shouldn't expect our healthcare professionals to be going above and beyond. The problem is some women's experience would indicate that the support they're getting, the quality of it is inconsistency of advice. You know, it seems to be a major issue, and it is. And we see that from parents, but we're also seeing that being admitted by healthcare professionals as well. So the idea of our first sub-theme, Chance Encounters, it was really around staffing and resources at the time and place of the support that's needed. So this is an example here. There's parts of the rural county do not get the service. It's like everything's a postcode lottery. Parts of it we cover, parts of it with the bordering counties, you know, some bordering towns, they don't get the service because of their location and the distance to travel. And that's seen consistently across both north and south. There isn't a staff expressing room here. So it's a big problem. If you're in a pediatric hospital, and again, you get a pump in for your room, and then we do have shared expressing rooms around the hospital. Both sides have pumps that we can give a loan to a parent, but we can't guarantee it. So in that kind of crisis where maybe a mum turns up to a hospital, she probably hasn't thought to pack a pump, or maybe she's never needed to use a pump at home, and suddenly now the hospital is now scrambling to find a pump to help support that woman and that family. Very little informal sense. I'm trying to think if there's any out there. It was less than an hour. And I suppose that I would have been highlighted at this point when I had my own kids, because suddenly I realized I don't know anything about it. And that was around their own knowledge and support that they could feel. And that was from a GP as well. And we have to do that every year in all staff members for us to maintain our baby friendly accreditation. So I do think the training is good that we deliver, you know, as a mandatory. You can't opt out of it. You don't have any choice. And so that's a really positive, that if you are maintaining that, you know, baby friendly accreditation, or it's put in as a policy, then we know that it works. We know that then people get the training, they get the knowledge, and then they're able to support. But when it isn't mandatory, or it's just seen as a very niche area that those people only need to understand about infant feeding, then we're not getting consistency. You know, it's only the children's hospitals or the maternity services needed. But what happens if we've got a mum who is sick and has to move to an adult hospital? Who's there to support that family, and where does that happen? So again, like I said, going above and beyond. So this was kind of coming across a lot, that, you know, that they got the support when the healthcare professional went that extra mile, went above and beyond, went out almost outside the remit, or, you know, to help that family. And we know that healthcare professionals do all that time. Now, I'm not throwing bouquets at myself, but you do have to go above and beyond in this job, if you've got any humanity, because the structures that are in place are insufficient to meet people's needs, not even close to being sufficient. I've been in contact by counsellors who are supporting parents in direct provision. I provide online consultations free of charge. I may not necessarily be able to get into them, but a lot of these people don't necessarily even know where their local supports are. And again, that's a private lactation consultant giving her time for free. We are so lucky in that we got quite an international staff. So sometimes if it's 3 o'clock in the morning, we might actually have a staff member who speaks the language. Now, that's not a perfect way of doing it, because they're not trained as translators, but we're asking them to work outside their scope of practice, but in an emergency, we will do it. So that was an obstetrician talking about, you know, maybe having to call a staff member that they know spoke that language, who mightn't be on shift, and they were coming in and helping, or on the phone and helping. I know there's some lactation consultants who do pro bonos, because they know counsellors who have parents who can't afford lactation consultants who need one. And again, it just shows the lack of structures that are in place within healthcare systems, that, you know, healthcare professionals are having to constantly go above and beyond, and not have that time downtime, you know, that they're doing it in their free time, they're giving up extra time, and then that's not helpful in terms of retention and burnout and crisis that's within the healthcare system as well. Really, the other one that came across a lot was the variability in provision of breastfeeding support for training for healthcare professionals. I suppose I don't really have many people that I can hand over my job to. If I'm taking annual leave, there isn't really anybody that can pick up much of what I'm doing. Chronic understaffing in terms of midwifery, that a lot of the time the midwives do not have enough time to provide adequate support for the mother to achieve a breastfeed. And as a result, formula is suggested very quickly without exploring all the other options to try and keep the mother exclusively breastfeeding. And that was a consultant neonatologist. And this is a midwife specialist. I think the overall knowledge of lactation is substandard, and our biggest issue is, as I said before, getting the staff to attend education. And if they did, they would be well prepared to support mothers with breastfeeding. And lastly, this is a midwife. I felt very ill-equipped to help people with breastfeeding there because my previous experience was on delivery. And so not matching up experience with services as well, or, you know, again, the understaffing within our hospital services is causing a lot of issues and difficulties in order to be able to have probably the time to train, but also the time to support parents. So I guess this second theme was circumstances, or sub-theme was circumstances and care. And we were talking about then the accessibility and delivery of support appears to be related to individual circumstances or family at the time of need. So the background and ability, the context of the pregnancy and birth, and cultural considerations as well. So taking that first one, background and ability, I mean, it was of pure chance. It was local knowledge and local network that got support to them. But sometimes they don't even have access to kettles. Even those small things like access to a kettle can be a huge stress for a woman going home. They might be quite far away, and transport into attending appointments is huge. And that was from a social worker working with some vulnerable groups. I'm seeing this on an increase now is a lot of foreign nationals who are living in substandard accommodation, who don't have a village, who don't have friends, and are really suffering and are really struggling. We recently had parents who were deaf, and again, getting interpreters, you know, it's very difficult for the parents. You really do feel for them. Women are not using, you know, the bottles correctly or not sterilizing properly. And there is a concern about that, and that does happen. Women who have private healthcare and have lactation support, the women who are marginalized, who don't have that privilege, unless they're attending the community midwifery team, then they're not going to have that support. And if they don't, they're not going to, if they don't, they're not going to have it. So again, it's really circumstances around that and where, you know, we're coming from a social economic point of view, or our ability to communicate in English in this case, that will affect whether I can actually access those services as well. The second kind of sub-theme that came out of it is the context of pregnancy and birth. So, for example, in a C-section mum, where milk can be delayed, those mums need extensive support in order to keep that baby off formula, but we don't have the staff to do it. Formula is often offered very quickly, same as with gestational diabetes, where there's a high risk of the baby developing hypoglycemia. So that, coupled with poor staffing, is, I think, the big reason why half or more than half of mothers that are intending to breastfeed leave the hospital not exclusively breastfeeding. And that's a consultant neonatologist. This is again is a different neonatologist. We do have really good dietetic support and lactation consultant support now for our mothers in neonatal intensive care. And this is a pediatric dietitian talking about, if a parent had to stay there, they would have had to have a lactation specialist because they have those roles in a maternity hospital. But when they come up to us, however, now at this moment in time, they're not going to get that. So it's really inequitable. So maybe you have sick baby being moved to children's hospital, maybe mum still in the maternity services or gets discharged, then they don't have that support. I guess in Ireland, there's donor milk, but it really tends to be prioritized for kind of small, sick babies. And even recently, we ordered donor milk with the maternity hospital and there wasn't enough. So we had to make a decision around that. So, you know, when we're treating children, it doesn't matter what you do. It's a process of discussion with families. And so, yeah, it can be hard. And so even when you're talking about getting it, there isn't always a security of supply of even that donor milk. And then we have cultural considerations. And as we are a more ethnically diverse culture, we actually are going to have to think about that. If we're thinking about what's happening in the conflict in Ukraine or refugees, you know, the current crisis with Libya now, we may have more international protection and refugees coming in and needing our support. And we're going to have to think about how we can support that. Interestingly, I think I shied away from mentioning breastfeeding at all to certain groups, because I know that group were like, two of the practices that I have worked with before have significant traveller population. And I just feel like they think you don't understand them at all if you mention it, because I know and they know that culturally it's not appropriate for them. And you nearly feel like you've lost ground in terms of the relationship because you mention it and they're not likely to get it. So again, even this is probably one of the groups that have really low breastfeeding rates, but we're now afraid to talk to them about it because we feel like we won't understand it or we will build barriers to it. I'm not going to go through all the quotes because I'm now getting a time signal. But I think it's nice changing. What's nicely changing everywhere is that we don't make presumptions anymore, that every parent, you know, especially for medical, that there will be a discussion that your baby would benefit from your milk and we'd like you to express it. And this is how we can support it. And so I think the conversation has changed, which is good. And last one I'll do, if we're talking about refugees and people like that coming from a culture that wants to breastfeed, so they will absolutely be doing it, you know. I'm just going to move on to theme number 2 because I know we're. So the other one we talked about was critical connections, and the sub theme is really missing pieces. And so there are gaps, and we could see that when we talked to our healthcare professionals, we had major gaps in support systems and referral pathways, and that had a huge negative impact on the accessibility to support infant feeding. It's much more difficult with asylum seekers because we're not always informed by the Home Office or MIRS, although we're trying to work very hard around, you know, but where they've been sent and where they are. So people often are in maybe refugee centres and then suddenly they're up and moved to another part of the country with very little notice. And, you know, those pathways aren't always picked up as well. There's systems issues for how asylum seekers and other new people are moved around the system. They're just as they're putting down roots in one community, they get moved, and that's a big problem. And we saw that from several people. So that was one gap. And then the other kind of thought is around referral pathways. They should automatically be referred to once they arrive here at all as refugees. But unless as refugees, they're automatically referred to the public health nurses, we don't know that they're there. The only time we find out they're there is when another baby is born. So again, that support is often coming too late. Most people, it's a tick box scenario. Okay, I've referred you on and they can walk away. And so thinking about that is as a difficulty as well. And we need to think about, do people understand the referral pathways and are they followed up? The other one is around, and we kind of brought it up at the end of our discussion in the last one, is around communication and collaboration. And I won't go into too much detail because I think Liz will cover this as well. But we are talking about, you know, what is the role of statutory organisations versus the role of voluntary organisations? If there is a crisis, how is that going to work? Because those volunteers are also probably going to be experiencing that crisis. They live within our communities. So if our community is affected, how are they going to be affected as well? And if we are reliant on those volunteer organizations, often they're very flexible and can work, but do people know about them? How are we going to get that information out to people? And what is the role of then statutory organizations like our health system that is going to protect those? And many of our volunteers are often healthcare professionals or have roles or jobs within the statutory organizations and maybe pulled that direction. So our reliance on volunteer organizations is not always possible during emergencies. And building those networks, understanding it, understanding where the links are and where the connections are, and it's not just chance as well. So I think this is a nice quote of how it's working well. For National Breastfeeding Week last year, I decided to run a coffee morning to try and improve communication among all the people that support breastfeeding. We ended up with 19 people. It ended up being an absolute runaway success. And since then, we communicate better now. And I think that's a nice positive example of what can do well. I think that resource and the value and expertise of those peer groups is lost in the crowd, especially when there's a top-down governmental approach. And that's why we need something that is set up beforehand in normal times, that the group or organization or network has a plan for how we would be involved in an emergency time. And I think that's really at the crux of what we wanted to do with our plan. I'm going to just skip on, so apologies. So I think what we need to think about is those critical connections and how we can fill in those missing pieces to make sure there isn't gaps in the provision of services. If there's gaps in normal times, there's going to be bigger gaps in emergencies, and make sure that people know how to refer on and where those referral pathways are. And so have that down. If infant feeding isn't your expertise, who can you refer on to? And that's that's what's just needed, rather than having everyone experts in things. Building networks and statutory and voluntary and the roles of that, and planning on how that's going to work in an emergency is important as well. I think we've probably covered everything. What I will say to you is that there is a diverse range of healthcare professionals represented in this research. So we think that's a real strength. However, I do acknowledge that those people that probably took part also have an interest in infant feeding. So we might be missing some gaps as well. And what we would like to say is in Northern Ireland, most of them are community-based healthcare professionals that are involved. So we would love to recruit a few more people, particularly within the acute services. I'd like to thank Lorraine, who did all this work, also to one of our public health nutrition students in TU Dublin who did this, some of analysis around this as well, for her final year project as well. And my last one is there is a QR code, and we'll be sending this around as well. If anyone knows of anyone, this will link to an expression of interest form, and hopefully we will and get a few more people within Northern Ireland to get that kind of data collection saturation that we're all hoping to look for. And thank you very much for listening, and any questions. I think you can circulate that one. Yes.
Hi, I'm Pauline McKeown. I work as an infant feeding lead, and actually around this table there's a lot of infant feeding leads from Northern Ireland. I also work with the UNICEF Baby Friendly team. We're governed by UNICEF for our standards here in Northern Ireland, and we have to follow accreditation. Is there something similar in Southern Ireland that, you know, training package, everything is looked at from a statutory body and is monitored so that mothers are getting the same information right across the board? And these standards are also in neonatal and our Sure Starts, which would be our voluntary services as well. And we are looking at bringing them into our children inpatient hospital. Standards are going to be set alone as well. So is there something similar in Northern Ireland so that information is the same?
Yeah, I'm going to let Liz step in on that one.
Yeah, I believe that Laura McHugh, the Republic's National Breastfeeding Coordinator, may be online as well, but new kind of standards for infant feeding were published in the Republic in 2022. So that's being rolled out. And so individual maternity units at the moment are kind of doing a self-assessment in terms of what their baseline is. So that's underway in all of the 19 maternity units. And so that's kind of the beginning of the process of a new baby-friendly initiative. So at the moment, the process is kind of at the beginning stages. You know, of course, most of the midwives and public health nurses will have, you know, training in infant and young child feeding. Particularly there's kind of a 20-hour breastfeeding course that they would have received. But we're at that stage now of assessing kind of, you know, more healthcare professionals beyond just our midwives and our public health nurses. So I think we're just at an earlier stage of that than you guys here.
I'm sorry, could I just follow through with that? We also have a National Infant Feeding Network. So as infant feeding leads, we share information across our 5 trusts. Is there something similar as well down south?
I don't believe there's anything formal. So that I think that's our problem, is these connections are made informally, you know, and a lot of people will know kind of who to talk to, or if you put the word out, I'm looking for XYZ piece of information, you know, people are ready and willing to engage, and you know, people can, you know, work well together, but it's not yet formalized.
And that's where we share an awful lot of our practices and good practices and what's happening in each area. And we work really well. Plus, as a lactation consultant and working you can be quite isolated as well. So providing that support for infant feeding leads is really paramount in supporting mothers, because if they feel supported, then they're going to support mothers too, you know, so families. Thank you.
Great. I'm just conscious of the time, so I'm going to thank Aileen. I think Samantha was due up to introduce me, but I'm standing here so I can introduce myself. Quite happy to do that in the interest of time. And so I'll do that just as I am going to change the slides that are being shared. So thank you very much for having me. My name is Liz O'Sullivan and I am a lecturer in nutrition at TU Dublin. And so I'm one of the PIs here on this project. I do voluntary work with Baby Feeding Law Group. I've worked in infant and young child feeding research for over 15 years now. And so along with this project on infant feeding and emergencies, I'm currently working with a core group to develop a World Breastfeeding Trends Initiative report for the Republic of Ireland. So it'll be the Republic's first WBTI report. So we're excited and looking forward to that. And so, like Aileen, my piece that I am sharing with you guys today is a preliminary analysis. So I would request that screenshots are not taken and shared widely. And also then I'm going to jump in and declare for Aileen that neither Aileen nor I have any conflicts of interest. And the only funding received for this project comes through the Health Education Authority, which is delivering on the North-South Ireland research programme. So while Aileen has described kind of the themes that were developed by Lorraine in terms of, you know, what healthcare professionals talked about infant feeding support generally, you know, looking at kind of our normal times, a little bit of a hint of what we need in emergencies. I specifically looked at the data to understand what people were saying about what we need to have in emergency times. And I was looking at the data across healthcare professionals and volunteer support groups. And I will say that actually the presentation was prepared for the conference, you know, maybe 10 days or a week in advance. And we have actually had a couple more interviews in Northern Ireland, but they weren't, you know, on time essentially to be incorporated into the data. So we are getting there, but we are still looking to interview more people. So I just want to start by acknowledging, as Gráinne did this morning, that, you know, we're not looking to reinvent the wheel here. You know, we are aware that there are many people who have done excellent work in this field, and we are going to be, you know, using and drawing on that guidance and then developing, you know, additional resources or tools or plans that would be specific to the context of the Republic of Ireland and Northern Ireland. So we are immensely grateful for the work that's being done, you know, internationally in this area, and we are, you know, really hoping to learn from that and capitalize on that. So just brief comment about emergency management, which is not my primary field of expertise, something I'm learning a lot about. But if you look across kind of emergency plans that are available in the Republic of Ireland and in Northern Ireland, there are 5 kind of broad phases of what they would call emergency management. So you've got your hazard analysis or your risk assessment, broadly called prevention. You've got your mitigation measures where you're trying to manage the risk. your preparedness, and then your response and recovery. And so this kind of cycle is loosely split into response and preparedness. So, you know, you are kind of getting ready for something happening to set everything in place. And then whenever it happens, you're ready then to respond. And anything there that looks like a pair of breasts was purely by chance, and I'm spotting it now, but a happy coincidence. So what I'm going to do is, and again, you know, preliminary analysis, I'm going to talk you through what some of our participants are saying about what we need in terms of preparedness and what we need in terms of response. These are the things that we are currently thinking about and thinking about working on how to feed those into our plan. So in terms of preparedness, again, building on what Grania mentioned earlier, is that we need to protect, promote and support breastfeeding in advance of any emergency. So our participants really recognise that a population that has a greater prevalence of breastfeeding is more resilient. We need to ensure access to human milk. So whether that relates to that point 1 of protecting breastfeeding or looking at donor human milk, that's kind of what people were talking about there. We need to ensure effective communication is in place. And I know Aileen has spoken a little bit about that, so I will build slightly on that. And then also providing clarity around who is responsible for infant and young child feeding in emergencies. So these are the things that people were talking about in relation to, you know, how do we get prepared? So this first point about protecting, promoting and supporting breastfeeding in advance of any emergency, one lactation consultant described her experience of when it was snowy and she actually personally was exclusively breastfeeding, but she was looking at neighbours who were, you know, formula feeding and really struggling. And so she said a lot of people who couldn't make formula, they'd no electricity, no nothing, and there was nobody near, and they couldn't get out of the roads. And so she built on that to say healthcare professionals can get that message across in a way that's not being forceful or condescending or judgmental. And it could be one of the things to help women choose to breastfeed. You know, again, this is talking about what we mentioned earlier about, you know, highlighting, you know, the immunological associations with breastfeeding and really trying to explain to people these are some of the reasons that we think this is a good thing to do. Another said if it was a major emergency and there was no access to anything, children could be given breast milk if the mother is lactating, older children if they needed it. And so there was a case in the US in 2006 when a woman was stuck in the snow in her car for I think it was 9 days, and she had a 7-month-old and a 4-year-old, and she sustained both through breastfeeding, even though she had kind of long given up breastfeeding the 4-year-old, but, you know, came back to it again. So again, this is just highlighting that we're actually a more resilient population if we have more people lactating. And another pointed out that I do believe it's the best way to feed our infants, and probably especially within the cost of living crisis as well, it's free. I think again, this can be a bit of a contentious issue. It's free if we are providing appropriate support and protection. You know, people aren't needing to buy pumps, and if we're acknowledging the time and effort that requires of a mother. But you know, in theory, that could be a route to go down. I find people may not appreciate that message quite as much because it is, of course, so time consuming. So the second piece on the preparedness was ensuring access to human milk banks. So the only milk bank on the island of Ireland is in Enniskillen in Northern Ireland, and it opened in August 2000. And it serves the 27 neonatal units in hospitals across Ireland. And we do have a service, a voluntary service, the blood bikers. And so the blood bikers should also be called milk bikers. And so they will transfer the milk between the milk bank and the various neonatal units. And also if you have like a woman in an acute hospital herself, separate to a maternity hospital or the pediatric unit, they will transfer the milk between those two locations. But again, this is a voluntary piece, and a lot of people spoke about the milk bank in our research. And, you know, in a time of crisis or emergency, you know, we talk about continue and maintain breastfeeding where, if that's not possible, provide donor milk. And one of the key things that people talked about was we don't currently have enough donor milk for the tiniest neonatal babies. So this isn't a viable option in an emergency because we're already stretched with this service. And so a dietitian said, you know, they could go down the pasteurized donor milk, but we don't have a service like that. Like in the UK, they have community milk banks. We just don't have that here. We only have enough milk for our sick babies. Again, infant feeding lead, it's hard enough for the human milk banks to get that at the minute for those babies in need. And another saying, in nursing management, we prioritize the neonatal babies at the moment, and that takes all of the resources that we have. So there's really a kind of strong recognition here that this would be a lovely thing to have, but we do have this one milk bank that is servicing all of these neonatal units. So it's not a resource that we could draw on in an emergency, and potentially having just the one milk bank is a source of an emergency. It wasn't that long ago where there was an issue with the processing of the milk at the milk bank, and some of the milk had to be discarded. And I know that through personal experience. I received that letter about my own 3 litres that unfortunately had to be discarded. But in that case, I know there was a lot of work done to try and source an alternative source of milk. But again, having something really clear and being ready for that is really important. Ensuring effective communication is in place. This was something that our participants talked about, and Aileen kind of commented on this. And a lot of the healthcare professionals really kind of spoke about having these links with the community support organizations, and making sure that participants know that there are service users know that those organizations are available and in place. I'm hopeful that kind of the new standards that are introduced in Ireland, and more hospitals moving towards baby friendly. That's one of the requirements of baby friendly, that mothers go home knowing all the supports that are available in the community. So hopefully that will kind of improve things. But the other key thing that was talked about was making sure all these people are at the table and talking together, and then after that making clear who is providing this link to the parents and babies. And so part of the confusion here and part of the issue here will be really, I think, well indicated or highlighted on the next slide, which kind of brings us into who has the responsibility for infant and young child feeding in emergencies. And that clarity is really needed. Whose job is it? Because Aileen described some individuals are going above and beyond, and they're taking it on themselves when it may not necessarily be their job, and you can't be relying on that because it's inconsistent. So when talking about who's responsible for infant and young child feeding in emergencies, who's the captain of my little ship in the top left corner there, the responses were just across the board. So one thing I noted was that public health was consistently talked about in North and South. So someone said somebody that is informed about infant feeding, so I'd imagine a public health nurse or a midwife. Another said the public health nurse is obviously a key role, ideally somebody with a specialist nursing and an awareness of social needs. And another said, whenever an area crisis management team has to be convened in response to an emergency, public health are there. So this was really kind of recognised as the obvious source of support. And another thing that was commented on in terms of both public health nurses in the Republic of Ireland and the kind of health visitors who would be the equivalent in Northern Ireland was that these are the people who have the local knowledge. They will tend to know, if we're planning an emergency evacuation site, well, that site may not be so good for these particular reasons, or this place may be better. So they were really recognised as the kind of local on the ground experts. But of course, it's not currently within their formal remit to be doing this. So, that's a problem. We're relying on their goodwill. Others then said, we would all have a role, but what you're asking is who leads this? And I suppose I'd maybe talked myself into thinking that it sits with social services. So another saying, through the conversation, that's who they felt may be involved. A social worker in the Republic said it would probably be up to the people accommodating them. And maybe I'm responsible for these people coming in. So a little bit of a light bulb moment there saying, actually, is it me? And so another said, if you're looking at very rural areas, it's going to be a community approach as much as possible. And so we've talked about how, people living a bit further out are at a disadvantage because they don't have access to care, and you're relying on, the community rowing in and supporting. So it's really murky. It hasn't been clearly defined, and that is leading to what Aileen talked about, those gaps being opened up and people relying on, luck in terms of the care that they receive. So I think one kind of summed it up well, saying it has to be driven by those in power, but we will all need to be discussing, sitting down and having that plan in place. And that's kind of what we're hoping to do now, and hoping to kind of get the word out that we want to talk to more people, we want to engage, and particularly in the next phases of this research, we're trying to cast the net even wider to get all those people at the table, get everybody, on board with the message. So in terms of response then, there were 3 key things that were talked about. We've got culture, practical issues, and then the role of the voluntary support groups or organisations. And in terms of culture, this was looked at in 2 ways. It was talked about people from other cultures coming into Ireland. So, looking at things like inward migration of people who have been displaced elsewhere. And the key piece that was acknowledged here is that the cultural norm in their new adopted country is to not breastfeed. And it's terribly important to be attentive of that. So people really recognise that we have a lot of people coming into Ireland who may have a historical culture of breastfeeding, and then all of a sudden they're landed in a place where formula feeding is the cultural norm. So another said people who still come in with good knowledge of breastfeeding and support, or breastfeeding, of course, but they're lacking things like family support. And sometimes the process that either led to their migration or the process they're going through leads to psychosocial issues, which of course is a barrier to effective breastfeeding. So acknowledging that people are going to need more support. And another recognized that very sadly, people, they take on our culture, and this is related to changes that we observe. And this is reported in, the published literature in Ireland, that we see acculturation over time. The longer somebody is in Ireland, the more likely they are to formula feed. And just in terms of kind of practical ways, it was acknowledged that people, if they have a history of breastfeeding and a strong culture of breastfeeding, and formula feeding is not their norm. They're not clear maybe on all of the processes involved. And one described a service user from another country not understanding sterilizing. And she said, maybe it's because of their culture, they breastfeed, but when I was sterilizing, she was looking at me confused. So this mother had been using formula, but didn't understand that, bottles needed to be sterilized. So that was one way that culture was talked about. And the other was, which I've mentioned, this idea that we have a formula feeding culture in Ireland. Again, something that's been published widely. So, acknowledging this needs to be included in our plan. A dietitian said, the whole thing by collecting formula to give out, you absolutely can't do that. But there are people that have chosen to formula feed and will need to continue to formula feed. So acknowledging that is the cultural norm. And, recognizing again the resilience of lactation, somebody said in another culture, if there were 10 women, only one would be bottle feeding. So you could do informal sharing. In Ireland, that would be a huge issue because a lot of people wouldn't be lactating. So again, getting at that, if you're trying to kind of, draw on other sources of milk, you're not going to have as much of a supply as you may in other cultures. And in relation to relactating, somebody in nursing management said, unfortunately, there's not many would do that. I've only known a couple of mums. Another said then, in terms of borrowing somebody else's breast milk, ideally it would not be at the breast because of cultural practices. It's a difficult area in Ireland. So acknowledging that, some of the messages that we may observe in response to crises in other countries, and we're talking about, maintain breastfeeding, if not establish wet nursing, if not maybe look for another source of breast milk. Those messages may be less acceptable in our culture. I think depending on the type of emergency, eventually, everybody wants the baby to get something. I think eventually things will become acceptable, but I think it has to get to quite dire before the Irish culture will switch to that. And I think one midwife summed it up really well, because she said, I don't know, it's a bit off the wall, but like people that have breast milk, then I think should be able to breastfeed other babies. I don't know that that'd be very acceptable in Irish culture. I just find it interesting that, something that is consistent global messaging is being described in Ireland as off the wall. So it just really goes to show where we are starting from. So using all of this, I tried to do something, I said I wouldn't reinvent the wheel, but I've tried to do something that, many others have done before. And this is absolutely not a definitive final version, but, just looking at an algorithm of how people would feed or would, feed their babies in an emergency in Ireland. I created this monstrosity. And so, you might look at, did the mother ever lactate? If yes, is baby still being breastfed? If yes, well then continue that and support. And so this is with the caveat on the left that the baby is under 6 months and mum and baby are together. So obviously many of these would need to be created for all of the different scenarios. But if you look down the left, like this is what I kind of see as being the issue in Ireland. Like if you go down the left, so did mother ever lactate? No. Is donor milk available and acceptable? Likely no, because it's only there for the preemies. Is shared milk acceptable and available? Again, likely no. I think acceptable is the big piece there. And I've actually put shared milk first rather than wet nursing, which is contrary to the guidance, I know, but I think it's based on that idea that culturally it appears the wet nursing is perhaps going to be less acceptable. So it's a real challenge, because then as well, if you're looking at shared milk, is there clean water? Is there facilities for washing bottles and providing that? So there are so many challenges, and you get to the point where, is a wet nurse available and acceptable? Is formula available and acceptable? If so, do we have hot water, all of the ability to make that? If yes, maybe powdered infant formula is the way to go. If not, we've got our ready to use formula. And if we go all the way down this left point, we're going to have to go back to these people and re-explore options around wet nursing and sharing milk. So, there's no easy answer here, but I do think that, we will have challenges with this in Ireland because of our formula feeding culture. So in terms of the practical stuff that we're described, we've got a lot of usual suspects, and some of these are covered extensively elsewhere, so privacy, space, the capacity to make up feeds safely. And I think one of the things that I probably haven't mentioned of is this kind of idea of free access. So if you've got folks in a reception centre, acknowledging that the parents of younger children are going to need more access to a kitchen. You know, I know I haven't spoken too much about complementary feeding. Again, these are preliminary analyses and I will be building that in, but acknowledging that, you know, a small baby is going to need far more frequently. You can maybe have adults and serve them 3 meals a day and they'll get on with it. They might not be too happy, but they may get on with it. But your smaller children, you can't do that. So even small things like providing more access is important. In terms of communication, having information in a variety of languages and formats, so text, images, and videos. So there are some populations who don't engage very well with written materials. And so having videos might be better for them. You have the issue there maybe of, you know, electricity, and there are all sorts of things obviously to consider. And then communication via social media, which Aileen pointed earlier, you know, in our original survey, social media was where people were getting their information. And I think it's really where we are on the back foot in terms of healthcare professionals and researchers. We are slower to kind of jump on that bandwagon. And I still can't bring myself to use TikTok, even though I know all my students are on TikTok. And, you know, every year Aileen and I meet the students and we're talking about setting up Twitter accounts, realize like, you know, kids are not on Twitter. So, you know, we need to get a little bit better about that. And then also key to not have formula donations and not displaying any preference for a formula brand. So it hasn't come up in any of the quotations, but one thing we observed in the Republic was that a couple of reception centres only had one brand of infant formula available. It was the same brand and it was the most expensive brand that one could buy in a shop. So like when we had refugees from Ukraine, this is what they were getting exposed to. And we know, as the companies know, that the first milk that people are exposed to is the one that they're most likely to stick with. So how inequitable is that we have people coming to our country and we're providing them with the most expensive brand of infant formula? And so it was summed up really nicely by an infant feeding lead in Northern Ireland. So no matter how they're feeding, they're going to need somewhere to prepare themselves or the feeds. Feeding equipment, have sterilisation equipment, access to fresh running water to wash hands and equipment. For breastfeeding mums, they need a safe and comfy sort of area that they can go and have access to equipment for expressing or storing of breast milk. So, you know, it's not rocket science. We all know this, but it's trying to make sure that that is available to people. And of course, again, I suppose I want to put my hands up for anybody in emergency management. I think we all know that the plans that we write are like the best possible case scenario. You know, we know, depending on the nature of the emergency, not everything is going to be able to be implemented. But if you have an idea of what should be there, you can do your best and, you know, and maybe do better than we did in the last emergency. So that's what we're hoping for. You know, we're not going to be making demands of emergency management that they absolutely categorically have to do all of these things, but having the plan in place is going to make it more likely that they will happen. And so finally then talking about the role of voluntary groups, and this really came into our piece because of what people had said to Aileen and I in 2020 about, you know, the likes of the voluntary groups providing online support more quickly, but also then, you know, having that much more work to do. So we talked about what people felt the role of voluntary groups was. And so it really kind of varied depending on, you know, the opinion of the individual. Some felt there wasn't really a role here for voluntary groups during an emergency. And, you know, that sounds perhaps maybe inappropriate to some in the room, but part of the reason for that was that some were recognizing that it should be people in paid employment who are doing this. And so the end of this quotation is saying, rather than the volunteers who were giving their time, like they're giving free evenings and weekends, I think we might lose the goodwill. So, you know, acknowledging that the volunteers are already doing a lot, we need to have people who are paid to do this response. And another recognised that a lot of the La Leche League leaders are parents of small children. And I don't know how that would work for them if they were also caught up in the emergency. Another said, I couldn't see us bringing volunteer groups into an emergency, but we could have telephone support for moms if English isn't their first language. So some felt, you know, maybe it's not appropriate, whereas others were saying, well, yes, there is obviously a clear role here. And like was mentioned earlier, somebody recognised that La Leche have, you know, information in a whole host of different languages. And so, you know, maybe if that were more widely known, that could be the first port of call. Like, is there something already there from La Leche League that we could use? And so recognising that that was important, but also then acknowledging the scope of practice. So if something needs an onward referral, then that needs to be done, which of course we need the referral pathways in order to do that. Friends of Breastfeeding volunteers said if we could have a suite of resources that we could deploy if there was a crisis, we could put that message out to the people following us and we can play a role in that way. So acknowledging that communication can be key. And then someone was saying, like with emergency accommodation, if there were lots of people in one area and lots of families and people were breastfeeding, I'm sure people would help. So, you know, still saying they think that people would step up. And a midwife said definitely CWIDU and those community supports would play a role for sure. So it really kind of varied depending on who you were talking to. And I suppose in our kind of personal communication with the team, we felt that, yes, maybe there is a role here. But we think that communications, so to service users, are going to be really important. They have access to these networks. But roles for volunteers in emergency need to be clearly defined. You know, rather than just asking them to step up and keep giving of themselves, it needs to be clear what we're looking for. There should be remuneration considered for the supports or assistance provided. So, you know, like it was acknowledged, people are already giving so freely of their time. And so considering payment for that is not unreasonable. We need to bear in mind that volunteers are likely parents and may also be healthcare professionals. So, you know, we see that, you know, a lot of the healthcare professionals that we spoke to, you know, lactation consultants who are also CWIDU leaders. So, you know, they're doing a little bit of everything and they can only be pulled in so many directions. And acknowledging that these volunteers are already plugging the gaps in breastfeeding support in non-emergency times. So again, you know, perhaps we're looking at a system that provides better support and assistance for them. But we've also noticed as well that emergencies deplete the resources of voluntary groups. So some of our voluntary groups talk to us about kind of their cycle of recruiting new leaders and new volunteers. And, you know, with COVID extending 2.5, 3 years, there was a period missed there where new leaders were coming in and you're coming to the stage maybe where leaders have babies who are 5, 6, 7, and maybe they're looking to get out, you know, they're maybe a bit over the breastfeeding period. And I know some stay on considerably longer, but a lot rotate out. And some of the groups are noticing now that actually they're depleted. So that's a real challenge as well, particularly if, you know, likely with climate change, we'll come into repeated emergencies one after another, which is going to be a real struggle. So I suppose in conclusion, we feel that food security for children needs to be prioritised and addressed immediately so that we are as resilient as possible in the face of an emergency. And so this is kind of tying in with something that's happening currently in the Republic. The Children's Rights Alliance currently have nominated this as End Child Poverty Week. And so that's running from Monday to Friday this week. And they're talking about, you know, income in the early years and, you know, ensuring kind of security for those. But we think that at the heart of this food security is protecting, promoting and supporting breastfeeding in these non-emergency times, which will require education and training for all healthcare professionals and those involved in emergency response so that everybody can work together on this. So I would just like to thank Lorraine, who is our master's student, who collected all of the data, and then Ross Mooney, who is a human nutrition and dietetics student who did some analysis of the data. All of the participants were really grateful for the input that everybody has provided, and the Health Education Authority, who are our funders. So thank you guys very much. Wait, Elizabeth, you might just turn on the mic in front of you. Yes. Thank you.
Hi, Elizabeth McCarthy, La Leche League, lactation consultant and academic researcher in breastfeeding with Trinity. There was just a couple of points I wanted to make. First of all, it's great that it's a community approach. And I'm just thinking as well that because we're specialised and we do need more lactation consultants and all, there is a tendency then though that people refer then to the lactation consultant only, or we have to wait till somebody else is there. So I think what's coming out in your research as well, came out in my own, that GPs are sort of the main primary link for most, and yet they are probably the ones that will say that they have the least training. And that's, I think we really need to be looking at the GPs, the primary healthcare centres and pharmacists, because I think that's where families tend to go for everything. Mm-hmm. And we can't expect everybody to be an expert, but it's the basics that most mothers actually need, and not, you know, there are cases where they need to be referred on. And I think most voluntary groups will know very well their scope of practice and will refer on. But for the majority of cases, mothers need time and basics, and that's something that we're very short on. Just one thing I wanted to say about the internet and phones and stuff was just, I was remembering back to the New Orleans disaster. And the first thing to go there was the phones and the internet. So nobody had any access to anything. So I think we need to kind of think about, you know, well, going back to basics in a lot of ways about how our communication gets across. And just, I can see your point with the breastfeeding support groups and people and then talking about money and all the rest. And like most volunteers probably wouldn't take any money anyway, even if it was given to them. Because it's a different sort of thing. But I think the breastfeeding support groups are crucial. But it was just one thing that came up in my research, just maybe to caution you as well. When mothers talk about breastfeeding support groups, they actually include the public health nurses as well. So when I was doing my PhD, I actually included the public health nurses. But it's mostly mothers of young children, or say up to 6 weeks, that would go to them, and then they kind of move on to the other ones. So yes, greater communication as well. They were just the 2 points I wanted to make. Thanks
Great.
so much, Liz.
Thank you. And just to reflect back on the piece you mentioned there about the GPs, you know, we're in a nice position at the moment. There seems to be real kind of tide turning, because I know, you know, Denise McGuinness and Sarah Brennan are doing work in that area. So people are, you know, recognizing this need and are kind of pushing for it. And also, you know, part of what we're doing with WBTI will highlight those needs as well. So particularly in the Republic of Ireland, and I'm sure WBTI UK will have some comments as well. No pressure, Helen. Thank you.
Claire Alcott, couldn't make many points, but just on the GPs, it's great that Denise and Sarah are doing that project. But I set up something called the GP Infant Feeding Network of Ireland a few years ago, and it is an all Ireland if any GPs are interested.
Great, thanks. And I think Ray might be the final point. Sorry, thanks, Ray.
Thanks very much. Look, I suppose one of my points, and I've said this to a few people in the room already, is, and people online, we are unfortunately a special interest group that talk to ourselves and are really convinced this is the right thing to do. But there's a much bigger community out there that aren't convinced and aren't prioritizing this for infants and mums and for families in need. You know, we talked about standardization a couple of times and sharing best practice, which is actually all very good, but we often set up our standards in isolation. What we really need is a more broader based service framework that has metrics that are easily measured, regularly analyzed and reported on a regular basis. That has to be part of normalization of normal behavior. And that's really what is going to have to go against the culture. And we're going to have to insist on a prioritization for children and mums, so that we actually have a healthy future with improved outcomes for children and an improved well-being for the whole population. That is really, really a struggle at the minute. So talking to policymakers within either Department of Health, you know, they're not really that interested. Yes, they'll get a media headline, but they won't necessarily have follow through or provide additional resources on top of what's already there. So with the best will in the world, we need more prioritization, and it may well mean having to make splashes in the media, as unpopular as that is. But this is really vital and important, because if we can't normalize it within what's normal, we're going to really struggle when it comes to delivering within a crisis and an emergency.
Yeah, and I have found through some kind of informal conversations, so again, not necessarily for minuting, but those people who are providing most pushback on this get on board with the milk bank. Like they can see that, they see that more clearly as potentially being a problem. And I've just found that really interesting in conversations where people aren't quite catching on to what I'm saying or getting the importance of it. They will get on board when the milk bank is described and potential challenges there. So, you know, it could be, you know, kind of a strategic way, maybe as using that as a primary message and bringing everything else in with that, you know. Yeah.
I couldn't agree more.
Okay.
But I am biased.
Okay, so thank you very much for all of your attention. I really appreciate that. I'm just going to stop sharing my slides so I can see the time. Okay, so we're running over time, but for the folks who are online, thank you very much for your time and attention. We're going to take a break until 1:30, and we will be back. I think we should start back on time. So I'm just going to share a QR code for anybody who would be interested in engaging with our research, particularly any healthcare professionals from Northern Ireland. We really do want to hear from you. So please do get in touch with us. You can link onto the QR code, and we will begin the next session at 1:30. For those in the room, we have some lunch that should be just outside the door that we can bring back and continue the conversation. Thank you very much, everybody.